Hello and welcome to Season 2, Episode 86 of the Physician Assistant Exam Review Podcast. This episode, we're going to continue with the GI tract, mainly talking about, I'm already fumbling, mainly talking about the large bowel. And then as we go through, instead of just at the end, we're going to talk on a very specific study tip that is might just change the way you look at everything. Hang on, we'll get to it. My name is Brian Wallace. I'm the founder and creator here at Physician Assistant Exam Review, where we help struggling and overwhelmed PA students navigate and get the most out of PA school and ultimately pass the PANCE and land their dream job. Before we get started with the large intestine today, I want to let you know that I'm going to be having a huge PA week sale. It's actually just this giant package I put together. I usually like to do that around Thanksgiving, but I thought PA week would actually be a better time to do it. And it's a giant package I put together of some of my best material. And what I'm doing is I'm putting it all together into one box and taking 60% off of what would be the normal price on that stuff. So all combined, I'm not going to separate it out. If you have one small piece of it, I'm sorry, it's just going to come as one package. And at the price it's at, I think you'll understand that even if you have one of the items in that package, it'll still be totally worth it. For various reasons, that product is not available today. Happy PA week. I'm actually recording this on Monday, so this PA week starts tomorrow for me, but today for you. It's a little confusing with the time lapse. But this package will be available on Saturday for a couple of reasons. It won't be available today. It'll be available Saturday, Sunday, Monday, Tuesday, and on the last day of PA week, which is the 12th, which is Tuesday the 12th, it will be going away. So if you want to check that out, you can find it at www.physicianassistantexamreview.com/PA week. Again, go check that out at www.physicianassistantexamreview.com/PA week. If you're on the email list, I will happily remind you on Saturday about it. If you're not, I recommend you get on it because that's where I cover tips and tricks and how-tos for just about everything that happens with PA school on a daily basis. So I think that's incredibly valuable. But if you're not on there, go check it out and I will be there to remind you as well. All right, so let's jump in to our priming questions for this week. Explain what a diverticula is. Explain what a diverticula is. Is Crohn's or ulcerative colitis that can be found along the entire GI tract? Is it Crohn's or ulcerative colitis that can be found along the entire GI tract? A cobblestone appearance on colonoscopy should make you think of what diagnosis? A cobblestone appearance on colonoscopy should make you think of what diagnosis? Abdominal pain out of proportion to physical exam should make you think of what diagnosis? Abdominal pain out of proportion to physical exam should make you think of what diagnosis? Keep your ears up. Those are some solid questions I think you'll come across on your exams, and I'm going to explain why as we go here. We have a couple important definitions I haven't covered yet under GI, and I think now is a good time as I'm running into them as I go through the notes for each section. So I thought we'd cover them here. Number one, we have abscess, then we have fistula, then we have stricture. An abscess is a painful collection of pus, usually caused by a bacterial infection. So it's a collection of fluid and pus, generally caused by the immune system fighting off bacteria, but it's kind of that pocket that is sealed off and under pressure. A fistula is an abnormal connection between two body parts. This can be a little hard to visualize, but today we're going to talk about some diseases sometimes when the lining of the colon of the large intestine gets a little hole in it. And then what can happen is secondary to some inflammation in that little bit of a hole, it can attach itself, let's say, to the bladder. And then it kind of wears through and you get a connection between the large intestine and the bladder, and materials can pass through that connection. That's a fistula. Can obviously be a major problem. A stricture is a narrowing of a space. So we did esophageal strictures not too long ago, so we can get bowel strictures as well. All right, normally I keep this to the end, but today it just makes more sense to include it as we go, which our study tip for today is going to be differentiating diagnoses and disease states. It's going to be really important, and I wasn't planning on using this as my study tip for today. I know I've used it in the past, But this section just lends itself so nicely to this way of thinking. And I think it's something that a lot of people don't notice and don't consider as, especially as first-year students, as much as you've had accomplishments in school and in learning, and as much as you've been able to achieve, one place I find people struggle is that they continue to study in the same way they've always studied, which most people tend to be smart enough to get by on brute force alone. I like to start talking about different ways and techniques for studying, for test taking, for all of these things, and using, for lack of a better word, using technique, using tools to help you use the brain you've been given, use the brain that you've trained, but we're going to push it even further. So today our study tip is going to be differentiate diagnosis, and I'll explain as we go exactly what I mean by that and how it's so important to this particular section, how it will increase your grades on GI in particular, but definitely throughout all of medicine. It's something I focus on very, very much. All right, so let's go ahead and get started. Diverticular disease. Diverticular disease, having a diverticula or pockets in the colon. So diverticula are these little outpouchings in the wall of the colon. So it's a weakening, and it can be where a blood vessel passes through the layers of the colon, and under great pressure from the digestive process, over time, you can get these little outpouchings of the large intestine, these little pockets that form. These are called diverticula. Diverticulitis is an inflammation within the diverticula. So you can picture if you have this little pocket and something gets stuck in it, like I know they recommend people don't eat, let's say, popcorn when you have diverticulitis, or the people have discovered you have diverticula in your bowel, because the little seeds might get caught inside of one of those little pockets. And you can imagine if it gets stuck in there, it can cause irritation, it can cause inflammation, and lead to diverticulitis. That's one example. Obviously, there are lots and lots of other ways that you can go from having these little outpouchings, these little diverticula, to frank diverticulitis. But it's an inflammation of those little pockets. Endoscopy and colonoscopy are contraindicated in an acute setting due to the risk of perforation. Again, picture these little out pockets. They're weakened the walls of the colon are weak at those points. So you don't want to go in and add pressure. You don't want to go in with a scope during the acute phase. Once it's settled down, you certainly can go in and look around, and that'll be how we diagnose this. But during that acute phase, you just want to get everything calmed down. Clinical presentation. These patients will come in with acute abdominal pain. They may have a fever, nausea, and vomiting. Again, it depends on how bad the inflammation in that area is. They may have very little symptoms, or they may have very severe symptoms. They can have left lower quadrant tenderness. These tend to form the most in the left lower side. They may have a left lower quadrant mass that might be palpable. If they have frank diverticulitis, a CBC will have elevated white blood cells. And often they'll have fecal occult blood will be positive. And when that's inflamed and weak, and the walls are weak, and you can definitely get bleeding from the wall of the large intestine into the lumen of the large intestine, and then you wind up with a positive fecal occult blood test. So how do we diagnose this if we don't want to use a scope? Well, we do a CAT scan. A colonoscopy you're going to use later on down the road once the symptoms have calmed down, because once the diverticulitis symptoms have calmed down, it's not as if you aren't going to be able to find it. What are you going to find if you do a colonoscopy? What are you looking for? You're going to look for those pouches, right? You're still going to find the diverticula, even if the diverticulitis has calmed down. So you're going to wait to get that under control before you use a scope, and you're going to use a CT scan if you need to before that. Treatment. Mild to moderate disease can be treated conservatively. So the clear liquid diet, oral antibiotics may be used, like metronidazole and Cipro. And you're going to get that calm down using a combination of antibiotics, a clear liquid diet, and maybe some anti-inflammatories. Severe disease, you're going to be NPO. You may need to do IV fluids and IV antibiotics, and the patient may need to be admitted. In a very bad situation, they may require surgery. You may have to remove the diseased portion of the colon with a temporary colostomy. So you would just go in and you'd cut out that section of the colon that has that diverticula, let everything calm down, then put it all back together. You're going to want to educate these people that a diet high in fiber can be helpful and low in red meat. And then next we have ulcerative colitis. Actually, the next two we're going to cover are ulcerative colitis and Crohn's disease. These are two that go hand in hand. They are two what we call inflammatory bowel diseases. And when I talk about learning to differentiate diagnoses, to differentiate these diseases, you're going to find on your test that very commonly they're going to ask you to differentiate between two things that are very similar. So in this case, you're going to be asked to differentiate between ulcerative colitis and Crohn's disease. I'm also going to use diverticulitis here because it has a similar presentation, right? We're talking about someone who comes in with abdominal pain, severe abdominal pain, and perhaps a fever. You're going to have to look at this patient, whether it's on the table or in your exam room, in your clinic, or on a test, reading through the vignette, looking for clues, just like you'd be looking at a patient looking for clues, and try to figure out if this patient coming in with abdominal pain, first of all, can go home or needs to be admitted to the hospital, and second of all, what the actual diagnosis is and how to treat it. So that's what we're thinking about as we go through, or as we see a patient, or as we see a vignette. How are we going to handle it? What are we going to do? So as I go through ulcerative colitis, you're going to be looking for the things that are going to steer you towards ulcerative colitis and away from everything else. So when we talked about diverticulitis, can you think of one or two things that sort of might help you differentiate it from everything else? There is not a lot to go on. Maybe one of the few things is left lower quadrant pain and tenderness. Right, a lot of times when we talk about abdominal pain, we're talking about central pain and tenderness around the umbilicus, or we're talking about right-sided pain with like an appendicitis, a colitis, those sorts of things. When we're talking about left lower abdominal pain, that points us towards diverticulitis. Doesn't mean it is diverticulitis, not at all, but it points us in that direction. If they have left lower quadrant pain, you're kind of not thinking appendicitis. And that's how your brain has to start to work as you work through these questions, but also as you see your patients. So let's move on. Like I said, we're doing ulcerative colitis. This is an inflammatory bowel disease that involves only the mucosal surface. That's important because Crohn's disease is transmucosal. It goes through the mucosal surface, and ulcerative colitis only goes through the mucosal surface. That's one way they can differentiate it for you on a test question. For ulcerative colitis, the rectum is always involved, and the more proximal colon may be involved, but it's always in a continuous pattern. So what does that mean? It means that the rectum is involved in ulcerative colitis. This inflammation of the bowel begins at the rectum and then moves proximally in a stepwise fashion, a continuous pattern, up through the colon. It can affect the sigmoid colon and continue to affect further up, but it does so in a continuous pattern. Clinical presentation, in this case, these patients have attacks of crampy, painful diarrhea. The diarrhea is bloody with mucus. Again, you may not see mucus as a key term in a lot of these things, but mucus in the stool should certainly make you think of ulcerative colitis. More than 6 of these per day equals a severe case. So these patients may have a fever and obviously abdominal pain. Lab studies and physical exam findings, they will have blood on digital rectal exam. And again, in their history, most likely they will describe bloody diarrhea. They can have abdominal tenderness. You're going to get a CBC, a SED rate, labs for malnutrition for a lot of these, like B12, albumin, folate, and iron. You're going to get stool cultures. You should probably do that as well for diverticulitis. Obviously, they're going to be negative if this is going to be your diagnosis, but you're going to want to get them to make sure you're ruling out everything else. And a plain abdominal x-ray is always a good idea. On a sigmoidoscopy, you're going to see a continuous area of unhealthy tissue. Same with the colonoscopy. Treatment. In the acute phase, if they're pretty severe, you're going to make them NPO. You can use topical or oral aminosalicylate agents. So if you're going to do this topically, this is going to be with an enema or a suppository. Remember, this affects the rectum, right? So you're going to put that medication right where it needs to be. Or you could use these orally. The same thing with steroids. You're going to want to calm down that inflammation. So a corticosteroid is going to be a good choice initially in the acute phase here. Again, these can be applied either orally or topically. If these patients are severe and have continuous problems, you can surgically remove the portion of the colon that's having the problem. This will be curative for ulcerative colitis. But obviously, removing a portion of the colon is a big deal. But ulcerative colitis can be cured by removing a portion of the colon because, remember, it goes in a systemic continuous pathway. If you're not quite in that severe state, but you have a patient who's just dealing with this on and off, so this is a problem that comes up and goes down and flares up and goes away and flares up and goes away. Patients in the maintenance phase should have dietary management, so they require education here, increasing in fiber. They should have a diet low in dairy. I also read where they talk about avoiding raw fruits and vegetables, which may be irritating. And then topical or oral aminosalicylate agents are going to work here as well for continuous treatment, and that should be ongoing. You're probably going to stop the steroid at some point, but the aminosalicylates should continue. All right, Crohn's disease. Crohn's disease is our other inflammatory bowel disease. So when you get a test question that talks about a patient with abdominal pain, it's going to have the two choices, Crohn's and ulcerative colitis. Just like you're going to see Addison's and Cushing's as your last two choices on test questions for endocrine. You're going to have to compare these two. You have to learn how to separate them, how to differentiate them. Crohn's disease is an inflammatory bowel disease that is transmural. It causes inflammation and ulceration of the tissues, which can result in the formation of strictures, fistulas, and abscesses. So remember, this disease causes tissue damage all the way through the colon wall. So we can get fistulas if that's up against some other organ it's not supposed to be. The ileum and the colon are the two most commonly affected areas, but Crohn's disease can affect any area of the digestive tract except the rectum. So it spares the rectum. There's our major difference, or a major differentiation point. Ulcerative colitis affects the rectum. Crohn's does not. Crohn's can also affect any area of the digestive tract, although most commonly we just said the ileum and the colon. With Crohn's disease, the lesions are not continuous, which is a significant difference from ulcerative colitis, right? Of note, there's a significant increase in the risk for developing Crohn's disease in smokers. And again, symptoms here are relapsing and remitting over time. You kind of get a flare-up, then it gets better. Then you get a flare-up, then it gets better. Very similar to ulcerative colitis. Clinical presentation, low-grade fever, abdominal pain, frequent liquid bowel movements, weight loss, and diarrhea is usually non-bloody. Right, so here we have a major differentiator. If you have a patient come in talking about these symptoms and they've got bloody mucus like diarrhea, you're looking toward ulcerative colitis. They have very liquidy, frequent bowel movements, you're looking towards Crohn's disease. Lab studies and physical exam findings, inflammatory markers, C-reactive protein, elevated white blood cells, the malnutrition panel, a CBC, and then we're going to do a colonoscopy with a biopsy to diagnose this. Right, you could do a CAT scan to get a look at it. You could do a barium upper GI series. There's a lot of things you could do. But on your test, what you're going to find is a colonoscopy, which is going to show a cobblestone appearance and skip lesions. The cobblestone appearance is how Crohn's looks on colonoscopy. So if you put a scope up through the rectum into the colon, the tissue will look kind of cobblestoned. What does skip lesions refer to? Well, that should be pretty obvious. Skip lesions we have lesions in different areas of the colon and the small intestine. We don't have a continuous pattern. So you can see how we're differentiating Crohn's from ulcerative colitis. When I talk about it in this sense, they don't sound all that similar. But I promise you on a test, you're going to wonder which one is which. Try to hold on to these. So treatment. Encourage fluids to prevent dehydration. treat malnutrition, anti-diarrhea medications. Here again, you're going to use our aminosalicylate agents and antibiotics, metronidazole and ciprofloxacin. Steroids, you're going to go with a pretty good solid dose of 40 to 60 milligrams per day here. And surgery may be necessary, but is not curative. So you may have to go in and remove portions of the bowel that are really affected. But you really don't want to because you know it's not going to cure it, right? It can show up anywhere. So our treatments for these two diseases is basically the same as far as it looks here on paper. The one major difference is we don't do suppositories or enemas for treatment for Crohn's because, again, it doesn't affect the rectum and is usually further up the colon. Toxic megacolon. This is when the colon loses muscle tone, which results in massive dilation, secondary to colitis. So our causes are colitis. Medications can cause this, opiates and anticholinergic antidiarrheals. So you're going to want to stop those immediately if you run into this problem. Our clinical presentation here is someone who is very sick. They've had colitis and now they are extremely ill. They have severe abdominal pain, rebound tenderness, abdominal distension. They can have fevers, and they will have severe hypovolemia. Lab studies and physical exam findings, abdominal tenderness. And you're going to want to do serial abdominal plane x-rays to follow it. So you're going to want to treat the severe colitis like we talked about before. You're going to do things like keep them NPO, lots of IV fluids, stop all antidiuretics, stop all antidiarrheas. A nasogastric suction will help. Patients should roll from side to side and onto the abdomen just to move the air around. IV antibiotic therapy covering gram positives and gram negatives due to the fear of perforation. You're going to need steroids, and then possibly you're going to need to do a surgery to remove a portion of the bowel. All right, let's move into irritable bowel syndrome. These are recurrent symptoms. 2/3 of those diagnosed are female, so you may find that in your vignette. Clinical presentation symptoms last for more than 6 months. Generally, it's abdominal pain relieved with defecation, and they get a change in frequency or form or appearance of stool. Lab study and physical exam findings, normal physical and labs. Tests are only performed to rule out other issues like a CBC, a BMP, fecal occult blood, thyroid panel, and C-reactive protein. Treatment here is going to be symptomatic treatment, regular office visits to reduce patient anxiety, reassurance, modified diet higher in fiber, exercise, antispasmodics, laxatives, SSRIs, tricyclics, and probiotics have all been found to be useful. Next, we have ischemic bowel disease or ischemic colitis. So you don't need me to explain it to you to understand what ischemic bowel disease is, right? What's ischemia? Ischemia is when you're not getting blood to an area and it dies because of lack of blood flow. So here we have blood that stopped flowing to a portion of the bowel for one reason or another. I tell a story about a young kid I saw with ischemic bowel disease, and her problem was that her bowel was twisted, so it was cutting off the blood supply. Most of these you will find in people older than 60. It's pretty rare to find in someone so young. You'll find in people over 60. Due to things like atherosclerosis, don't mind me, of those arteries that bring blood to the bowel, right? So if they get clogged, we don't call it a stroke, right? That's blood to the brain gets blocked out. We call it ischemia of the bowel. Similarly, a history of atrial fibrillation will put you at an increased risk for ischemic bowel disease, vasculitis, any hypercoagulable state. Use of vasoconstrictors like vasopressin or cocaine will also put you at an increased risk for ischemic bowel disease. And if you think about it, it all makes sense. Don't memorize these, understand them. Then you can recreate the memory. Understand that cutting off blood supply for any reason causes ischemic bowel disease. So come up with some reasons why it would happen more to people over 60. Clinical presentation, severe abdominal pain. Bloody stool is certainly possible. If you get ischemia, you can get the tissue dies and ruptures within the colon. You can certainly get some blood flow where it's not supposed to be. You can get diarrhea, you can get fever, you can get shock. Lab studies and physical exam findings. Here's our big key term for ischemic bowel disease: abdominal pain out of proportion to exam. And that's what set me off with the young girl that I saw, was she was in excruciating pain, far beyond what you would expect from her physical exam. It was very obvious that there was something else going on. Now, when I tell that story, I do so partially to illustrate that I don't know a whole lot about GI. Remember, I work in surgery, but not a lot in general surgery. So this is not my area of expertise, but it certainly set off red flags for me when I saw this girl writhing on the bed, and the diagnosis that we were working with was appendicitis. And it just didn't look like an appendicitis to me based on this one physical exam finding. So that's your key term there. So when we talk about abdominal pain, and we talk about, is it ulcerative colitis? Is it appendicitis? Is it pancreatitis? Is it diverticulitis? Well, if you have excruciating pain out of all proportion to anything that you see, red flags should be jumping up all over the place saying, is this ischemic bowel disease? Angiography is going to be our gold standard to test for that. But you could do a plain X-ray, endoscopy, and CAT scan. Now remember, we're doing pretty much all the same tests here because we're trying to rule out all the same diseases. So again, don't memorize for every one of these: endoscopy, CAT scan, sigmoidoscopy. It's not that helpful. Realize that if you're trying to work up a patient comes through the door and they sit down in your office and they say, man, doc, I've got this horrible abdominal pain. I'm really in trouble here. Can you help me? Well, what are you going to do? Right? You're probably going to order the labs we've talked about today. You're probably going to order a plain X-ray. And then you're probably going to order an endoscopy or a CAT scan or a sigmoidoscopy, depending on what way you're leaning or what you're thinking. So it makes sense. You don't have to memorize them for each and every disease if they're basically the same. Treatment for ischemic colitis, supportive care including NPO and IV fluids. If you have a real problem, it's going to wind up with surgery. You're going to have to go in and remove the portion of the ischemic bowel. If you have mesenteric ischemia diagnosed within 24 hours, you get them to surgery. Patients have a survival rate of 50% because obviously it can be a major issue. All right, so our study tip for today. Our study tip today was looking at the notes, looking at the diseases you're learning, and picking through as you go what differentiates them. Don't learn them individually. Don't learn them as individual pieces of data. That's really, really hard. It's a lot of memorization. It's way more than most brains can handle. Spend some time thinking about when you see them in the office or when you see it on a test. How is it going to be separated? How can a test writer use words to get you to one or the other? So for separating abdominal issues, how do you differentiate acute diverticulitis from ulcerative colitis? Think about it for a minute. If you're writing a test question, how would you separate diverticulitis from ulcerative colitis so that the person reading it doesn't get the same, doesn't wind up at the end and not know which one to pick? Can you just say abdominal pain? No, you can't. They both have abdominal pain. Could you say right or left-sided? Maybe. Doubt it. Both tend to be left-sided. Can you tell by how sick they are? Not really. Either one could be not sick at all to very sick. What about bloody stool? Well, they both could have blood in the stool. The one exam finding that pops up to me would be the mucus in the stool, or the historical finding. If you have bloody mucus diarrhea, I'm leaning toward ulcerative colitis. Does that mean it's not diverticulitis? No, not necessarily, but it moves the odds. It moves that bar a little toward ulcerative colitis. But that's the way you have to be thinking about it on the test. That's the way you have to be thinking about it in the office. And that's the way you need to be thinking about it when you study. How do you separate these? We talked earlier about how do you separate Crohn's disease from ulcerative colitis? Well, it was one or two major factors. There's a bunch in there, really. But what's one or two? Can you think of one? Skip lesions for for Crohn's disease. Ulcerative colitis moves in a continuous path. Crohn's spares the rectum. And you don't get bleeding with Crohn's disease. You don't get bloody diarrhea. Not as the hallmark sign anyway. So that's some ways you can do that, some ways to differentiate. And I try to point it out to you on the show as I go through them because I think it's incredibly valuable. And I want you to really start keying in on that and really start paying attention to that as you study. And I'm sure you're going to find amazing results in your test scores when you start to do that. All right, let's answer our priming questions. This was a big one, so take some deep breaths. A lot of stuff in this one. You might want to go back and read the notes on the website, www.physicianassistantexamreview.com. If you head over to the blueprint section, if you scroll all the way down to the bottom of the page, it says there's a little menu. It says blueprint. Click on that, and it'll bring up all the different notes I have on the website. And you can find this here. It might be easier to go through this while you look at those notes. Priming questions. Explain what a diverticula is. That should be pretty easy now. Explain what a diverticula is. It's a small pocketing or outpouching, in this case in the colon. Is it Crohn's or ulcerative colitis that can be found along the entire alimentary canal? Crohn's or ulcerative colitis? Crohn's. Remember, ulcerative colitis starts at the rectum and can move proximally, but it's continuous. Crohn's can be anywhere. A cobblestone appearance on colonoscopy should make you think of what diagnosis? Cobblestone appearance. Crohn's. Abdominal pain out of proportion to physical exam should make you think of what diagnosis? Bowel ischemia. I hope that it starts to make sense and how you start to see these test questions and how they're written and how we separate the different diseases and the different descriptions. That's a lot of what the final step was written about. The book I put together, we can call it a key term book, but really it's how do you differentiate these terms, differentiate these things on a test or in the office for that matter. All right, so happy PA week. For PA week, I'm going to ask you to do me a big favor. I'm going to ask you to recommend the show to a friend, a colleague, a classmate. If you've got something out of this and you think it might help somebody, please tell them about the show. That's what I'm asking you to do for me for PA week. I'm planning on helping a lot more people in 2022, and I'm going to need your help to do that. I can't get that to them on my own. If you find that the show is helpful, then please share it with somebody you think it might help. So happy PA week, and what I'm going to do for you is I put together a tremendous PA week package over at www.physicianassistantexamreview.com/PA week. Go check it out there. I think you're going to be really excited about what I've got going on, and I'm really excited to share it with you. Until next time, we're going to move down the colon and into the rectum. I know you're super excited about that, so I'll see you then. Take care.